Okay. Good afternoon, everybody. I'm so glad you're here. Welcome to the Symposium on a Smorgasbord of Medical Decision-Making Tools, Different Perceptions of Value. And I want to tell you, I've seen the slides, and this will be a delicious smorgasbord. You will be glad you came. I'm going to briefly introduce the speakers so that we don't take any extra time on this as we transition from speaker to speaker. So I'm going to introduce them all now. Now, we've had to boil down their incredibly impressive resumes into a few sentences, but I urge you to visit the websites for the tools and decision aids that they're going to talk about. First of all, Dr. Dobsha is director of the Center to Improve Veteran Involvement in Care at the VA Portland Healthcare System, and he's professor of psychiatry at Oregon Health and Science University. His research has focused primarily on suicide prevention and treatment of chronic pain. He is currently leading a VA Health Services Research and Development funded project examining stakeholder perspectives on the use of open notes in mental health care, and you're going to be hearing more about that. Over the past several decades, he has also provided psychiatric care in primary care settings and developed several co-located mental health primary care teaching and clinical programs. Our second speaker will be Dr. Schoenberg. Dr. Schoenberg is a practicing internist, director of research in shared decision-making in the Division of General Medicine at Beth Israel Deaconess Medical Center, and an associate professor of medicine at Harvard Medical School. The goal of her research is to improve shared decision-making about cancer screening for older adults. Since high-quality breast cancer screening decisions for older women require consideration of their life expectancy, breast cancer risk, and preferences and values, her work is focused on each of these. To help clinicians and patients estimate life expectancy, she developed and validated a widely used tool that you're going to hear about today in detail. To help other women make more informed preference-based screening decisions about mammography screening, she developed a decision aid on mammography screening for older women and recently completed a randomized clinical trial to test its efficacy. The effects were on knowledge, discussion with PCPs, and the number of older women being screened. She's also developed and is working on improved decision-making for mammography screening for women in their 40s as well. In recognition of her work, Dr. Schoenberg received the 2016 American Geriatric Society Outstanding Scientific Achievement Award for Clinical Investigation and a 2015 Clinician Investigator of the Year Award from the New England region of the Society of General Internal Medicine. Dr. Ming Tai Seal is a professor of the Division of Health Policy in the School of Medicine, University of California, San Diego. Her research investigates the practice of medicine, patient-physician communications, and healthcare economics. Her publications on patient-physician communication earned the Article of the Year Award from Academy Health. A co-authored publication on the practice of medicine in the age of electronic health records was the second most read paper in Health Affairs in 2017. In addition to her faculty appointment at UC San Diego, she is the Director for Outcomes Analysis and Scholarship at the UC San Diego Health Information Services and the Director of Research in the Department of Family Medicine. And then finally, Dr. Cottrell is Director of the Health Experiences Research Core for the Oregon Clinical and Translational Research Institute at Oregon Health and Science University. She holds a joint appointment as an investigator, a national at OCHIN, a national nonprofit dedicated to transforming healthcare in vulnerable populations. She earned her PhD in sociology from the University of Wisconsin-Madison, her master in public policy from Harvard University, and her BA in anthropology from Luther College. She has an active portfolio of research focused on understanding and disseminating patient health experiences. And again, you're going to hear about that today. She has worked on identifying and addressing social determinants of health and primary care and evaluating the impact of payment and policy changes on healthcare access, utilization, and outcomes in community health centers. In addition, she is vice chair of the Health Experiences Research Network Steering Committee and a member of the Research Advisory Committee for the Social Interventions Research and Evaluation Network. I haven't forgotten anybody, did I? No. Good. All right. So without further ado, it is my distinct pleasure to introduce Dr. Dabsha.
Thank you. I guess you should think of me as the appetizer for the smorgasbord. Today I'm going to be speaking about a project that we've done at VA Portland Healthcare System and OHSU. Not so much a decision support tool or decision aid, but really an education tool that we hope will have a positive impact on clinician-patient collaboration and other interactions. And I don't have any relevant disclosures to make. How many of you have heard of open notes? Excellent. Okay, I would say I've asked that question before, and every time I ask it, more and more people seem to have heard of it. I will give a little bit of background. Open Notes is an international movement that seeks to empower patients by providing them access to all of their electronic health records online. Many health systems, as you know, currently already provide people access to certain types of structured data in their records, lab appointments, or laboratory data, appointment data, pharmacy information. But Open Notes really, the movement attempts to facilitate health systems and patients really having access to the full record, including clinical progress notes. So the VA healthcare system nationally went live with Open Notes in 2013. And there really was, in contrast to most other health systems that are implementing Open Notes, the VA did not allow anybody to block access to particular types of notes, such as mental health notes. Everybody can see everything. And so what the impetus for this project was is that concerns have been raised over the years about patients who receive mental health care reviewing their notes. Could this exacerbate symptoms? Might people be confused? Could there be documentation about trauma? Or are there particularly sensitive issues that patients really shouldn't be looking at? So we set out to conduct a VA-funded project. It really had several key components. The first part was we did a series of qualitative interviews with 28 veterans and 28 clinicians inquiring about their attitudes and use of Open Notes. And by the way, Open Notes is often referred to as Blue Button as well, so you'll see that term in the presentation. So we gathered a lot of information from them. We also sought to identify themes that would serve as a basis for learning objectives for 2 courses. So we created 2 web-based courses, one for clinicians and one for veterans, with the goals really being to minimize unintended negative consequences that might occur with the use of Open Notes in mental health care, but also to optimize communication and collaboration. Really, how can we take advantage of Open Notes and really improve care? So today I'm really going to be talking specifically about the veteran course and really walking us through that. Before I do that, though, I just, in the spirit of the theme of this conference, I just wanted to talk about the potential value of this. So certainly from the patient perspective, you know, our hope is that this course will help them have a greater knowledge of medical topics and really the context of medical care, in particular the context of notes and the electronic health record. We're hoping that veterans can better understand their own care, participate more actively and with their providers, including in decision making, and really be more engaged in health. We do know from several studies on Open Notes that patients often do feel more in control of their care in general when they use Open Notes, and they may be more adherent to care. From the clinician side, we have some data from our study that would suggest that clinicians are often a little bit ambivalent about the use of Open Notes in mental health care, but they do acknowledge that it helps them keep accountable and probably does help them document a little bit more carefully, with the idea being that patients are paying attention. Courses can potentially be widely disseminated at low cost. And we also found in our study that if you don't talk to your patient about Open Notes, they're much less likely to read them. So I think that's another goal of all this. So let me walk us through some aspects of the course. And I should mention that we had a number of actors who helped us with this, but that the content of what they're talking about really is all derived from the patient and clinician interviews in here. So let me, I have no sound.
Soon after retiring, I realized that I needed some help transitioning back into civilian life. So I started getting treatment from the VA for my PTSD. And recently I ran into a friend at the VA who said I could access my health records by using the blue button. I was curious about it, but at the same time a little nervous, especially about reading my mental health notes. But my friend had told me that using blue button is a good way to keep on top of my health and to make sure things don't fall through the cracks. I think it's important to help with my own recovery, which is why I decided to try it.
I also want to mention that the way we developed this course, we had a stakeholder group of veterans and of clinicians. We worked with an instructional designer from the VA, also an education specialist, and there were several iterations of development. Just to show you a little bit about what's in the menu, we have various chapters that we've constructed, again, based on key themes that we got from the interviews that we did with veterans, and also reflecting some of the advice that people had for us during the process. We each section has an introduction and a summary, and I want to show you that there are some interactive features. So some fairly, it's not particularly fancy interaction, but it does require some engagement of the learner in the course. There's also several exercises that we've included to asking people questions, test scenarios, so that that we could help facilitate learning in that way. This is a challenge. This course is designed to be 30 minutes long, so think of a smorgasbord. I'm just showing you a few things that we've got included. One of the things that we're pretty proud of is this, we have an interactive sample note. And so I can show you a little bit about, if you click on a certain section of the note, it'll describe what's going on for the patient. So you can so we even have an introduction to templates and what templates are all about. We definitely focused a little bit on trying to activate patients more to ask questions. Because we also found during our interviews that patients are much more reluctant to ask questions, again, if the provider, especially if the provider hasn't brought it up. There are a lot of patients out there who are reading their notes and never telling their providers, and so we really tried to encourage them to be assertive. Because I'm running out of time, I'll show you a couple of other things. We did include a training evaluation so that we could collect data on the course, and I'll come back to that in a second. We have a glossary. We have a resources section which connects to a website that we can update pretty easily. And I'll just show you one other thing from the course, and then I'll talk to you about the evaluation.
Over the last few months, I've had some questions about my notes. And I found that being willing to say, hey, I don't understand this, makes all the difference. It's difficult to do, but I think it's worth it. As veterans, it's important that we play an active role in our healthcare. And sometimes that means asking some hard questions to get the information you need.
And then just to mention of the evaluation, course ratings that we obtained during the course, actually quite good. Some of the qualitative information we got there, some of the videos we had some trouble with, which seems to have been fixed, but there were also a number of veterans who were probably more e-health savvy, and they thought that some of the content was a little bit too basic. On the other hand, there were other veterans who weren't nearly as computer savvy, and they really appreciated it. So it's kind of a tough issue trying to figure out the audience. We also, we had 250 veterans who participated in a longitudinal evaluation and to look at potential changes in attitudes and behaviors over time, and did find some significant improvements in self-reported patient activation or engagement in care, as well as perceived self-efficacy in patient-clinician interactions. Well, I'll just wind up with a couple of veteran comments. This class has actually motivated me to want to know what I'm missing in my health care. And I've been using Blue Button for quite a while, not only for reviewing my mental health notes, but for reviewing lab results, etc. However, I believe that this training course will allow my use of the Blue Button to be more efficient and productive. And I would just say, if you really want to have people using Blue Button, then we really need to educate them. Clinicians really need to be educating people about it.
Thank you so much for this opportunity to give my Shark Tank pitch for ePrognosis. So what is ePrognosis? It's a web-based repository of geriatric prognostic indices. We designed it to make it easy to access evidence-based prognosis information on older adults without a dominant terminal illness. For example, not those with stage 4 metastatic cancer, because then their prognosis is really driven by their cancer. But for the more common patients we're seeing that have a bunch of different diseases, and we may need to factor those in to estimate their prognosis. What is prognosis? Well, when thinking about death, prognosis is the probability of death over a specific time frame. And when you're thinking about prognosis in terms of medical care, it's also important to think about the lag time to benefit of the care or intervention you're thinking about. And what is the lag time to benefit? It's the time between when an intervention is given and when improved health outcomes are likely to be seen. So for example, if there was randomized control trial data on an intervention and the survival curve separated around 5 years, but the patient in front of you doesn't have 5 years to live, it's very unlikely that the patient will live long enough to experience benefit from that intervention. And as part of ePrognosis, we also include guides to help clinicians discuss prognosis. So who's our target audience? Mainly clinicians. Primary care providers may use ePrognosis to target cancer screening and cardiovascular prevention medications to older adults. Oncologists may use it to target surveillance tests and therapy. Palliative care doctors may use it to help identify patients who need to clarify their goals of care and or to identify those who may benefit from hospice. Patients may use ePrognosis with their clinicians for shared decision-making. And ePrognosis actually receives 8,500 hits per month, and its use is recommended in hundreds of journal articles. Why prognosticate? Prognostication allows for patients and families to determine realistic and achievable goals of care. It allows for shared decision-making so that an intervention will achieve an outcome important to the patient and or their caregiver. It allows for clinical decision-making that takes into account a patient's likelihood of living long enough to experience more benefit than harm from an intervention, and it allows for access to benefits such as hospice. So now I'm going to talk about an example, and the example, if you know my work, is going to be around cancer screening. And in the cancer screening example, it's important to know that a meta-analysis of randomized control trials have shown that it takes about 10.7 years before 1 in 1,000 women aged 50 to 74 avoid breast cancer death as a result of being screened. And it takes about 10.3 years before 1 in 1,000 adults aged 45 to 80 avoid colorectal cancer death as a result of being screened. And because of these data, guidelines such as Choosing Wisely recommend not screening adults with less than 10-year life expectancy. So bringing this to the clinic, this is a case of a 78-year-old woman, a smoker with emphysema, osteoporosis, who presents for her Medicare annual wellness exam. She states her health is good, her son helps her with groceries and house cleaning. She does not have difficulty walking a quarter mile, but does have difficulty pushing or pulling large objects. She does not have family history of breast or colorectal cancer and no other major risk factors for these diseases. And her body mass index is 22. So, as a clinician, am I recommending cancer screening? How do I decide? So in comes ePrognosis. And for the sake of brevity during this talk, I did a bunch of screenshots, but I'm just showing you what you would see if you were using a website. So I'm interested in helping this patient think about whether or not she wants to undergo cancer screening. So I click that tab. She's a woman, so she's eligible for colorectal cancer screening or breast cancer screening. So I'm going to click both cancers. I'm then asked a series of 15 questions about her health to help estimate her prognosis. And these questions come from 2 validated mortality indices. One I developed using National Health Interview Survey, and one a colleague at UCSF developed using Health and Retirement Survey data. But there was so much overlap between the 2 indices that we combined them, and then you get output from 2 different indices to help estimate prognosis. So I put in that the patient's 75 to 79, a female, her weight and her height. She's in good health. She has COPD. She's never had cancer. She does not have heart failure. She does not have diabetes. She is a current smoker. She does not have difficulty walking a quarter mile. She has not been hospitalized in the past year. She does not have a health or memory problem, making it challenging for her to pay her bills. She does not have trouble with bathing or showering. She does need help with doing routine needs or getting around. Her son helps her with that. And she does need help pushing or pulling large objects. And for my answers to these questions, ePrognosis does its magic, and it shows me that for this patient, the harms of screening are much more likely to outweigh the benefits. And it also gives me a little bit more information. It says out of 1,000 patients like her, about 100 will experience some harm of screening in the first year of undergoing screening. And meanwhile, it takes 10 years for one woman like her to avoid breast cancer or colorectal cancer death. But meanwhile, in that time, 700 women like her will die regardless of screening. So for this patient, doesn't have much chance of living long enough to experience the benefits of cancer screening. And we also have information in ePrognosis, some of the benefits and harms of screening. So benefit being that just for breast cancer, a mammogram is much more likely to find breast cancer early, so maybe she would only need a minor surgery. However, screening may find breast cancers that otherwise would never have shown up or caused problems in her lifetime. So this may lead to additional tests and treatments that are burdensome and may be harmful. Well, back to our case. Well, this case was actually my grandma. And sure enough, her primary care doctor did not use ePrognosis. And sure enough, she underwent mammography screening because her doctor recommended it. And she was diagnosed with a 1.5 centimeter invasive ductal ER positive, HER2 negative, clinically lymph node negative, so a good prognostic tumor. She did choose to undergo breast conserving surgery and was started on aromatase inhibitor. She just decided to forego radiation therapy. But the aromatase inhibitors caused her bony pain, her osteoporosis to get worse, so she switched to tamoxifen. But that also caused her a lot of fatigue. So she stopped endocrine therapy at 3 years. At 6 years, she had a local recurrence. They re-excised the tumor. And then at 10 years, she did die of her COPD, as ePrognosis would have estimated. But before she did, she's like, Mara, I wish I never had that mammogram, because in my grandmother's life, breast cancer was more of a nuisance than anything that was going to help her live longer or better. So it is important to consider prognosis in these decisions. And I also wanted to show you some of the other tools available in ePrognosis. So if I don't want to go through the whole cancer screening tool, I can just go to the tools I'm interested in. So if I just want the prognostic estimate, I can click this patient's clinic, living at home. She's in the US. We actually have prognostic tools developed outside the US, which may be relevant to this crowd. I'm interested in 10-year prognosis. My patient's 65 or older. I then can just enter those health characteristics. And based on the information, it'll simply tell me the patient's prognosis in 5, 10, or 14 years based on my index. We'll also show you, based on the Lee index, her prognosis in 5, 10 years, and even estimates of her life expectancy based on her prognosis. And it's important to know, in using these tools, we often consider patients who have greater than 50% chance of death in a certain time frame to have a life expectancy less than that time frame, because life expectancy is a median survival of a population. And while it doesn't, like the math gurus, it may not completely line up, it usually does. And while I've been focusing on 10-year prognosis or longer-term prognosis, we also have tools for estimating shorter-term prognosis like 1 year. So if, again, if I have a patient in front of me and I'm debating whether I should talk about her goals of care, I can click that this patient's clinic living at home, she's in the US. I want to look at her 1-year prognosis. If she does not have advanced cancer, it'll take me to the Gagne index, which I then answer, and it gives me estimates of her prognosis over 1 year. If she does have advanced cancer, it can take me to the palliative performance scale, which gives me a median survival in days. If I don't want to do any of that, and I just want to use my index, I can go to the bubble page and just click on Schoenberg and get my index. And then we also have videos on talking to patients about stopping screening or prognosis in general when talking about reducing diabetes medications or even having goals of care conversation. And if you don't want to like listen to the 6-minute or 5-minute or 3-minute video, you can just go to the information you're interested in. If I wanted to see an example discussing lag time to benefit, I can click on that and get a video example. And coming soon to ePrognosis, which may be relevant to this crowd, is we're going to include links to decision aids that consider prognosis. So if you're using decision aids for older adults and it factors in their prognosis, please let us know and we'll link it. So here's my Shark Tank pitch. Consider patient prognosis so that older adults receive care with greater probability for benefit than harm. Many older adults would like to discuss prognosis with their clinicians to plan for their future, to make informed medical decisions, and to maximize value. Use of mortality indices tends to improve clinician prognostication, so it's important. So check out ePrognosis, and here's my co-developers. Nancy Schoenburn's in the room, so thank you, Nancy. And I'm happy to answer any questions later.
Good afternoon. So I'm going to talk to you about a cluster randomized controlled trial in 3 healthcare delivery organizations that were using computers to improve patient-physician communication. So this is a fairly, I think, a common impression that patients often have of their experience in the exam room. The computer seems to demand a lot of attention, and sometimes they felt that they are not the main target of attention from their physicians. And this is something that's somewhat of a perpetual issue that many patients experience even before the computer showed up into the exam room. So patients oftentimes hesitate of asking questions, expressing preferences because they worry about being labeled as a difficult patient. So we have done work in talking to patients during focus groups about their experience and challenges in clinical encounters. So the names of the patients are fake, but the statements are true. So this patient, let's call her Alice, she said, you have to be really articulate and you start the conversation. Otherwise, you may not have a chance to get a word in. Another patient, let's call her Betty. She goes with her husband to his appointment and he goes with her to her appointment because you can't remember unless you take paper and pen and write it down. But she felt sheepish about taking notes in doctor's appointments. So they accompany each other to these appointments and hope that one of them would remember what happened and what they're supposed to do next. And another patient, let's call her Catherine, she said, I think it may be most relevant to this audience. I mean, I ended up apologizing, saying, I hope I didn't upset you by saying I don't want surgery. It isn't that I don't trust you or like you. I hope you're not mad at me. And this doctor, let's call her Dr. Mayflower, she said, I often don't know why the patient came until going to the exam room. And the patient may say, oh, I'm here because you told me to come back in 2 months, 3 months. Here I am. So we did a pilot study that was funded by Patient-Centered Outcomes Research Institute, trying to incorporate patient activation and physician coaching interventions to encourage shared decision-making. And it showed some promising impact, which was published in 2016 in Health Affairs. And patients also seem to appreciate that the interventions that we had developed. So we are in the middle of this, a larger study that's also funded by PCORI, and it's taking place at the University of California, San Diego, and Reliant Medical Group in Worcester, Massachusetts, and the Sutter Health in the Palo Alto, California area. The aims of this larger study is to refine our intervention that grew out of the pilot study, do a large randomized control trial, and then to identify the strategies that has the most potential for sustained impact and replication across healthcare systems. So this is a diagram of the three-armed approach. We're doing the study in 3 systems in 21 clinics and about 110 providers. We do a baseline survey of patient experience first, about their experience of how well the physician engaged them in shared decision making. And then we randomize the clinics into what we call open communication high touch arm and the high tech arm and the ask arm. The high touch arm, basically we trained a few standardized patients who are actors, who are oftentimes part of medical schools immersive learning program. So we trained them to provide shared decision making and communication practice opportunities for our participating physicians, 30 minutes at a time, and the 2 sit-down sessions were interspersed by a visit with a real patient, which is audio recorded, and the standardized patient would listen to the recording in planning for the second sit-down with the doctor. And for patients, they'll receive a nudge through the patient portal to encourage them to think about what's most important, put that into the my chart, and then for the MA during rooming to incorporate that into the chart, and then for the physician to use a smart phrase to bring that in. So similarly, in the high-tech arm, all the things that we trained the SP to do were done by a mobile app that we developed. And patients do the same thing with compared to the high-touch arm. And then the ask arm, we just designed a poster. So it's low-tech, low-touch that's closest to usual care. And then we do a follow-up data collection. We survey another 40 patients per doctor to get their report about their experience with care. So we have a great multidisciplinary team, including software developers, user experience designer, SPs, SP trainers, and health IT executives and researchers and patient stakeholders. So this is what the poster looks like. It's bilingual. It basically invites the patients to talk about 3 questions about options, about pros and cons of each option, and the likelihood of the pros and cons or risks and benefits happening to them. So I've already talked to you about what the open communication interventions are. So for the high touch, again, it's with standardized patient. For the high tech, physicians use the app. And this is what the app looks like. I was too scared about technical difficulties. So like Mara, I also just took screenshots. This is a series of screenshots of the module on empathy, expressing empathy. So physicians, users have a chance to look at an introduction, some examples on how to express empathy that others have found to be useful, and have a chance to record how they would express empathy when the avatar would sort of float empathic opportunities, make statements that invite empathic responses. And then we end with self-evaluation by the user. We also have a module on shared decision-making. We use the 3-talk model, Glenn Elwyn et al.'s team talk, option talk, and decision talk. So that's a part of the app as well. So this is what patients see when they are prompted to answer the question about what are most important to them. So during each check-in, they're presented with that question. And we encourage the physicians to use this golden triangle of including the patient in the communication, even when they need to enter into the notes about next steps or do a little bit of charting. So remember our patient friend Alice. So to address her need, we give her a voice even before the visit through my chart. And for the doctor, we also help her understand what's the patient's priority before the visit. And for the second patient, we invite the doctors to tell the patient that she's putting into the next steps, and the patient can access it in the after-visit summary. And the last patient, who we're worried about asking about choices, we normalize that. And then the post-visit survey, we included the collaborate, the 3, question, and also facilitation of shared decision-making. So the study is in the field right now. This is some pictures of my collaborators at UC San Diego, and I am close to 7 seconds. Okay, thank you.
I may reference this if there's time, so I'm just going to pull this up. A second here. Oh, whoops. Steve, you know how to do this. Should I just go? Oh, it's okay up there. Okay, great. Excellent. Thank you, everyone. It's great to be here today. It's great to see some friendly faces in the audience who have been involved with the work I'm going to talk to you about. So I want to tell you a little bit about an approach to understanding patient health experiences that I and others have been working on for the past few years. Whenever I talk about this, I always want to go back to this story of a woman named Dr. Anne McPherson. She was a family physician and researcher at Oxford University. She was also part of the Cochrane group that does systematic reviews. And she herself was diagnosed with breast cancer. As a physician and systematic reviewer, she had so much information at her fingertips about all the different options she had, the causes of her cancer, the different types of treatment. But what she found, and what she soon realized, is she didn't really have a lot out there on what it was like to go through this, what it was like to be a patient, the different things people grapple with. So she and others, including a man named Dr. Andrew Herxheimer, and they collaborated with some researchers at Oxford University, they came up with this idea of creating a database of individual patient experiences. And I often like to say, and I feel like this group understands this, many groups that I speak to, since I'm a sociologist, don't understand this. I think the idea was they were trying to think of, like, is there a way to do sort of like a systematic review of patient experiences? So they went about trying to think about how can we use research methods to capture people's stories of health and illness. So this was founded back in 2001. The database of individual patient experiences was, that acronym is DIPEX. So this was founded by these researchers at Oxford, clinicians and qualitative researchers at Oxford. They also started a DipX charity that helped them and partnered with the researchers. Their very original aims as they started were to support patients and their loved ones who may feel alone or ill-prepared, to really support healthcare professionals in understanding more from patients, more than they can get in that 15-minute office visit, what's going on with them, and then really to promote better communication between patients and health professionals. So that was the beginning. And I'll tell you a little bit how they did this, and then I'm going to tell you what we're doing here in the US now. So this methodology was they really set forth some guidelines around this. So they would create what they called modules, and a module was like a series of interviews on a certain health condition. So say they wanted to do breast cancer. What they would do is interviewers would go out and they'd interview 30 to 50 people who have gone through this condition. These interviews are in depth. You generally go to someone's house. You don't have to go to their house, but in the UK, they're very keen on going to the house and having tea with the person. And they really, we've done both here in the US. Sometimes we don't go to the house. Sometimes people don't want us in their house. But you sit down with these people and you have them tell you their story. And I always like to say these kind of have two parts to them. There's really an open-ended part where you sit down and you say, please, can you tell me the story of your illness? And feel free to start wherever you'd like. And you let them talk and you don't interrupt. And that can last, I know Shannon and Sarah, who was here before, have done some of these interviews. So that can last 5 minutes or that can last 2 hours. And then after that, you do ask some more semi-structured questions where you're trying to you're trying to reflect on some of the things they said and pull out more information, as well as ask a few more questions. But really, you're encouraging them to tell their story of the illness and emphasizing the things that are most important to them. Another few key aspects is this idea of maximum variation, that you're talking to the widest range of possible people, that you're not just getting those people that are like really eager to share their experiences. You're not just getting all the good or all the bad. You're really trying to get out there and get a wide variety of perspectives. I think another thing that's really unique about this, a lot of the stuff I've described is qualitative research. People who are qualitative researchers might say, well, what's the big deal? I think one of the things that these folks were committed to from the beginning is broad dissemination. So the bottom is, I think, as you all know, what we usually do. We publish in peer-reviewed journals. They were also really committed to making these findings publicly available. So for each module or collection of interviews about a certain health condition, they would make a public website, and I'll show you an example of that. So they've done this for 110 different health conditions in the UK. They also make the data available for secondary use upon request. So all those interview transcripts, sometimes these are 3-hour interviews, those are archived. And if people want to use them for another purpose, they can request that. So this is the really beautiful thing about this model. This is an example of the website in the UK that I said has 110 different modules. You can see the range of health conditions there. Say you were to click on pregnancy in children, you would see there's actual modules on a range of different factors there: antenatal screening, pregnancy, screening for sickle cell. Within the module, what happens is the researchers are writing up summaries of the different aspects of experience that they found during these interviews and writing them in lay language, and really then illustrating them with audio and video and sometimes text clips from patients. So you can see on the left is the different types of sort of the parts of the story that people talked about, and as those come out, there's for each one of these lines, like it says experiences when the baby has died before labor starts, experiences of giving birth at 20 to 24 weeks pregnancy. Each of those would be about 300 to 800 words summary in lay language, illustrated with different clips from the interviews. There's also a part where you can see more about the person that talked with all of their clips in one place and sort of a summary of what their story is. People may be asking, like, what if people don't want to be on the website? It's very careful to give people control over how they are represented. People can choose not to show their face. They could just have their audio clips, or they could just have text clips. We recently did one with veterans, and about a third of them said, I don't want my face or my voice. They just wanted to have text clips, and I think that is equally as powerful. You're still seeing and hearing their words. So I'm running out of time, so I'm going to go quickly. What's cool about this, it originally started as a resource for patients and caregivers. There's been so many other uses since it kicked off. It's been a learning resource for students and health professionals. I think in the UK, over 90% of medical schools use some of these materials in their training. It's It's been used for quality improvement and to shape policy and relevant guidelines in the UK. And the National Health Service really talks about this as the gold standard for patient experiences research. And other countries have lopped onto this and formed their own DIPEX chapters. There's 14 now. Brazil is the newest one that's not listed here. And I'm just going to show you, each one abides by this methodology, but they all are a little different in the way they're in their website. Each have their own different website. There's Germany, Czech Republic was one of the newer chapters, Israel, Japan. And then the US. We're a network here that started in 2014, so we're still relatively new. Mark Helfand, who is one of the former, what did you call it, the president of SMDM, he was one of the original steering committee members, along with myself and others at University of Wisconsin-Madison and Johns Hopkins University and Yale University, who really kicked this off. We've since had some new nodes at University of New Mexico and University of Utah. Sarah Knight, who was here before, has joined our steering committee as well. We have, in the US, produced 2 modules so far that are done, one on depression in young adults that was conducted by folks at University of Wisconsin-Madison, and another on veterans with traumatic brain injury that was funded generously by the VA and some through OHSU, that started as a pilot project and then evolved into sort of a full module. And then we've been lucky to get some additional funding to continue this. So we have others in progress right now. A module on the experience of childhood cancer that I'm leading. We're going to be soon doing one on the experiences of adolescent and young adult cancer. And then another one on opioid use disorder. There's others going on genetic screening, breast cancer, clinical trial participation, and then one on Gulf War illness that's being led by folks in the audience here. Jennifer and Shannon are both involved in that one. And Sarah, who was here but no longer is here. So we have a website that we have a current website at healthexperiencesUSA.org, and it's being revamped as we speak. We're working with the DIPEX charity actually to kind of make it more robust as we grow to more and more modules. And with all of our work, we are really committed, as the UK has set forth for us, to having this website. We want to make sure that this gets out there to the public. It's a lot different than making a peer-reviewed publication. It's a lot of work to put together one of these modules. Each of them contains about 250 different video clips from the patients, but it is a way to really get that information out there. And then we'll also be retaining all of our data in a data warehouse repository that's available for secondary use upon request. One of the things we're continuing to think about, this started in 2001, it's now 2019. We have patient experiences all over the place, social media, blogs, YouTube, and a lot of health sites have a few patient videos or written stories. And so is this still relevant? And I think what I would argue is that these sites remain the only ones based on rigorous qualitative research to really get a balance of people's perspective, not just those voices that are most likely to come forward. We also are, hearing directly from those patients. So they're not actors on the site, they are actual patients. Some of them are more articulate than others. And then finally, I think the multiple uses beyond the original ideas and beyond just the website. Some of the work we're doing right now with our CTSA is really thinking about how we can use these methods and this information we're gathering to really understand patient perspectives and integrate that better into the research we're doing. So if researchers, instead of having a patient panel for every study, can augment that with looking at some of the materials we have either on the website or looking at the raw transcripts, that could be a way to better kind of integrate patient experiences into research, and really thinking about all the other multiple uses and ways of disseminating this across different sectors. So that is it. That's Health Experiences USA is what our website is called, and thank you so much for having the time to talk with you.
Well, thank you so much. That was really exciting. I would like to, as we're transitioning over to the discussion slides, to thank Carmen Lewis, who I managed to get up to come up on stage. And Carrie, would you please stand up? Everybody can see you. Organizers and intellectual leaders in this enterprise. So we're gonna have a little bit of wrapping it up discussion. Oh, we have the punchline here already, huh? No, that's okay.
Oh, no.
There we go. But I got you to come up on stage so that.
Yeah.
Ooh, it's like one. Back to the beginning. There we go. All right. Well, we're one up. It wants, it's on a timer. Yeah. I should do it later. For some reason, the keys are not working. There we go. I can tell you about it in words. There we go. Thank you, Bill. We should do the seventh inning stretch now, right? It's yeah. Well, you've sort of seen a quick flash of the slides anyway, so thank you so much. Hopefully the little advanced key will work too. So that was really, really amazing, the things that people are doing, very impressive. And just to take you quickly through some of the things that I think we might want to think about, and think about your questions that you might have for our question and answer period too as I'm going along. Dr. Dabsha talked about open notes. And you know, he put it by pretty quickly the incredibly impressive results of this tool. 85% of veterans would recommend it to another veteran. And I think that's sort of the acid test, isn't it? And he and his colleagues were able to achieve important goals like improving patients' knowledge and understanding, feelings of control and engagement. And these were achieved in the very difficult context of mental health. And I think you can all think about what would the difficulties be of having open notes with patients of all kinds, but in particular in this context. So this is a difficult goal to achieve. We're in an era in which openness is part of the zeitgeist. There's more and more call for openness in all contexts. People are talking about putting reviews for publications in journals on open sites where there would be, people would know the identity of the reviewer and be able to read the reviews. Graduate students at some universities, for example, are having all their evaluations be non-anonymous anymore. Some people have argued in both of these contexts that that encourages a kind of self-censorship, and certainly that is one of the concerns. And I would say, how do we mitigate against self-censorship by clinicians in this very difficult and delicate context, but at the same time empower patients, empower people? You know, this movement of democratization is going to increase. There's more and more emphasis on it and on patient empowerment, and that's a good thing. But we have to always keep in mind what's in the best interest of the patient as the ultimate bottom line. And I think you've chosen us a way to perhaps do that in ways we couldn't have imagined. Dr. Schoenberg told you about this impressive tool, ePrognosis, which will deliver things like the probability of harm, of death, of dying over a specific time frame. And I don't know if you could appreciate the degree to which these interfaces were remarkably intuitive and evocative. It was amazing the wealth of information that was conveyed and technical information, but in such a digestible format, I think, for all users. I would think about, in terms of thought questions, how malleable are these harms? When we talk about harms and time points and so on, there's always uncertainty around these things. So we worry about telling people about false positives, and that becomes a harm that's associated with screening, like for mammography and so on. But what if we could affect that harm? What if we can reduce that worry? So as we go along, hopefully we can take the malleable harms on the harms list and cross them off one at a time as a result of research by people like you and people like you. So what about the risk of perforation? Is that everywhere for colorectal screening? Is that equal everywhere? Is that just irreducible random variability, which could happen? Or are there things we can do to take that harm and cross it off the list? And what about change over time? As research moves forward and these outcomes improve, let's hope we're on a trajectory of improvement in many cases, not all, of course. But then these estimates become a lagging indicator, and we have to always keep that in mind, as well as the general notion of an average. An average on average is just average, right? It's not necessarily that individual. So always we have to think with the richness of this population-based summaries and averages, how do we take the individual into account and the context? Dr. Triceal, open communication, another incredible tool. And one of the things I thought was particularly interesting about this tool was that it was aimed not just at the providers or not just at the patients, but at the connection between the two, at both of them. For patients, it allowed the patients to organize their thoughts, to think about their options, the benefits, the risks, and the probabilities. But providers, I thought this was very interesting, were taught how to empathize. Now, often we think that empathy is just one of those things you're good at or you're not, right? We think of it as something that can't be taught, but it can be taught, and these kinds of results show that it can be taught. Theory of mind research says that one of the cornerstones to being able to empathize is the ability to understand the mind of the other. And this is something that does develop, and it's a key ingredient in things like moral reasoning. And this is a moral context to make decisions about the welfare of an individual. So this is something that is can be instructed and can be improved. And I think it's wonderful to think of empathy as an emphasis of this kind of tool. There are a number of dimensions that were mentioned, like high touch versus high tech, and they seem intuitive, but I would encourage us to think about process. What research says that that is the way to carve nature at its joints? Is that really the key active ingredient, high touch versus high tech, or can we drill down? What are the constituents of high touch that make that effective or not, or of high tech or make that effective or not? And one of the things I was really impressed by is the incredibly rigorous evaluation at every stage, and the ability to make a patient-centered approach a skills-based kind of approach. And finally, to think about the way to focus a patient's concerns as I really want to talk about. And that just dovetails beautifully with Dr. Cottrell's approach on patient narratives. And this is encouraging patients to tell the story of their illness, emphasizing the things that are the most important to them. And I just can't help resist relating it to, of course, GIST, which is something that I've worked a lot on. But in particular, we think about data is not the same thing. They're not information, right? You've heard that data are not information. But information is not GIST. GIST emphasizes the meaning of the information, the importance of it to the person. And there's some research and there's a review of the literature by Blaylock and Reyna that goes over some studies that talks about this. There's a lot that can be improved, and you'll see that from that review. And I hope that I can invite you all to think about that too. One of the things that's interesting about qualitative research, and this was touched on in your remarks, is that there's an active goal to represent the variability in perspective. And you think about the tension between a representative sample of patient experiences on the one hand versus a sampling procedure that says, here's a variable sample of experiences. And at first I thought to myself, we really want a representative sample, right? Because you want to think about what's the most common kinds of experiences and then the tails of the distribution. But I think I'm coming around to the variability idea. I think, again, if the goal here is not simply to predict what the patient's concerns are on average, but to appreciate with insight what the different kinds of concerns could be, I think then variability has a very important role to play. I think this is really a way to aggregate the anecdote, which you might think is not possible except that you've done it. And in particular, it reminded me when I was reading the patient's comments of a saying that I became familiar with many years ago, su voto es su voz. That is a saying. It says your vote is your voice. And I don't know if you know who Willie Velasquez was, but he organized the Southwest Voter Registration Project many years ago. He's not with us anymore. And he wanted to register people to vote. And he said, your vote is your voice. But when I read about this, I thought about this really is su voz es su voto. Your voice is your vote. Because by putting together the voices of so many different patients, that allows us to empower them to amplify their voices so that we can all understand better. So, that's the conclusion of my remarks. I want to thank the speakers again. And I gave us a minute and 29 seconds back. So we're open for questions now. So we'd be delighted if people would go to the mic. We'll be able to get you on tape, and I know you have questions. Thank you so much.
Hi, my name is Christine Gunn. I'm from Boston University. My question is actually about this idea of maximum variation sampling, because usually in qualitative research, you choose a couple of characteristics on which you try and seek out variation. And I was wondering what characteristics you're looking for. Is it clinical variation? Is it sociodemographic? Because I think that by limiting it to one or two of those things, you may miss other perspectives.
You've hit on such a good question, and something we just had a training in this methodology in New Mexico a couple weeks ago, and we grappled with this. And I think this is, people talk about maximum variation as like sort of the impossible dream and ideal. If we were really going to represent everyone in that way, we would be doing interviews forever. But I think you hit on a really good point, like that there is a slice that you do need to take. So for instance, when we did one on traumatic brain injury, we were really looking at mild to moderate TBI among veterans 18 and older. We were trying to get variation in race and ethnicity, time since injury, whether the injury occurred during service or after service. And so we sort of made that decision that those were the main things we were going to focus on. We know we didn't get everything. And so I think that's part of it, is just being really clear that, you know what, we may have missed some things, and there's room for more work. And so I think you hit on a really important point, and something that it's a tension that we're always kind of playing with.
Thank you.
Hey, Dan Matlock from Colorado. Thanks. That was great. I just wanted to ask sort of a broad question. Something I struggle with is this tension between designing things based on theory versus the newer design thinking where you're trying to have empathy to the end users, where you may not even know what theory is behind it, but it seems to be what's working. And since all of you sort of design something that's being used in this way, I wonder if you have any thoughts on that tension between those things.
I mean, I can comment on our project. We really didn't know much. I mean, so we had very little information about mental health care and open notes. So I think we were forced to use a very inductive approach and really derive from the veterans. We didn't really have a theory to begin with, I guess is what I'm saying. And it kind of ties into the last comment, I think, about, you know, one of the key purposes of qualitative work is to really generate new ideas that you need to do more research on. So I think this idea of trying to get a wide sample, I mean, I have to say, when we've done a lot of qualitative work in our center, and I'd say most of the time it's trying not to duplicate characteristics, I guess, if that makes sense. You just try to get as many different types of characteristics as you can think of to get an initial set that you're then going to work with.
So Dan, I think this is an excellent question. So ePrognosis really had no funding. So it came about because, you know, there were 20 plus different prognostic indices out there and nobody had access to them. And so if you develop it and nobody can use it, so we basically just had to get it online. And actually I was thinking I had to get my tool online, and around the same time they contacted me from UCSF because they had developed a similar tool and they wanted to get it online. So basically we got it online, but you know, having done decision aid work, it wasn't end user testing. I can tell you so many things that I would change. Our cancer screening tab that I did present, that was actually developed by a company for an app, but we turned out that few doctors are using apps, that they actually use the web page, and it's a lot of money to sustain an app. So we canned the app, but it's like linked in. So we actually can't make changes to the app right now, but we're gonna be changing that. So in some ways, the ePrognosis innovative team was like, we have to create it before we can make sure it works well enough and makes everybody happy. And now retrospectively, if we get funding for different things, we can try to improve its end userness. But I would say it's less research. I would have liked more time to create a tool that might have been more end user friendly. But at the same time, that would have cost years and nobody would have been using it. And we're getting the information that we need through actually people using it.
Yeah, that is a very provocative question. And we try to do many user-centered design workshops. So we worked with a design firm called IDEO. So because these are PCORI-funded studies, patient and other stakeholder engagement is really very important. So we did we did storyboards. We looked at what we understand from patients' voices and physicians' voices as well. For example, like about empathy. Some people say it's a innate skill, but there are actually literature that shows that it is teachable. It is a teachable skills. And then our physician colleagues say, give us the language, show us what's the body language to use, voice. So it's both in terms of based on literature and also on feedback from users. And we did it iteratively, over the years, and we've gone through many iterations. And so what we have shown here are product of those many iterations of user-centered design, workshops. But there are, theory. There are guidance from the theory, but I think we really tested how the end users' feedback can guide us in terms of what choices we eventually make. It's such a I think a varied field about patient-physician communication. People have different needs, physicians have different needs, patients have different needs. There's not a sort of a general theory of what's the best way to do it. So we try to catch what are the prominent areas of gaps and pain points and try to address those. And we try to design for the extreme users, and then hopefully the middle users will be helped as well.
I have to say something about theory, though. Remember the saying, there's nothing so practical as a good theory. A theory is about what people's experiences are. You can have a theory of that. You can test hypotheses. It's extremely important to be able to build on the wonderful progress of the people we've heard today, to develop theories and then to falsify those theories. And without cumulative building on prior knowledge, there's that terrible danger of reinventing the wheel. There is an answer somewhere in the literature. It's been shown, it's been found, but we're not taking advantage of it. We're not improving on it. So we're going right back to the beginning. So again, I think the wonderful work we've heard today is a perfect argument for being able to build cumulative theory.
Tom Newman from ECSF. Just a very quick question. I was very impressed, Dr. Rain, at how you would pull out these key points from each talk. On one of your slides, it said something about averages and the G21 problem. And
G2I, sorry about the acronym, group to individual.
Yeah. G2I, because I Googled G21 problem, and apparently on a firearms forum, the Glock 21.
Uh-oh. I'd like to deny all knowledge of that. Yeah, group to individual. I'm glad you mentioned that. I meant to explain that acronym. Group to individual is a problem that actually people in law, now don't all, get excited. There are nice lawyers, I swear. I work with some. And that is the notion that, it's the individual who's guilty. And this is a very similar concern. How do you take knowledge about human beings in general and what they're likely to do in general and apply it to the individual case for the person who's before you in court? And that's a similar problem that we have, that clinicians have. You think population knowledge, but you have to apply it to the person in front of you. So that notion of applying the group level truth to the level at the individual is a deep and important problem that's shared by many people. It's one of the people who've worked on it right here.
Hey there. I have a more technical question.
Oh, sorry, Erica.
That's okay, I'm short. I have a more technical question that both is relevant for this panel and then also some other panels where I've noticed people developing decision aids, and I have also developed web-based tools and struggled with the decision to do an app or a responsive web design or something like that. And I finished my project, and my funding has ended, and now I have no way to fund the maintenance of my tool. And so, you know, right now I'm struggling with the decision of, well, what money can I scrape together internally so I don't have to take down this website that I spent so much time and energy making. And then on the other hand, given the duration of the grant cycle and the 2 or 3 years that it may take me to obtain new funding, by that time the programming language has advanced. And so it could be that the programmers are going to have to redesign the whole thing anyway. So how have people dealt with the fact that what we build is very temporal, like it's very much in the moment, and how do we design something that we can adapt as we learn new concepts, as we integrate other components? Several people have mentioned, you know, we're building these components now, but we're hoping to add these other components. How have folks handled that?
That's a really important problem, and a brief answer maybe, so we can get into our last question. Does someone have a perhaps solution to sustaining?
Yeah, I mean, ePrognosis came out in 2012, and again, it's never been grant funded, but anytime like someone asks us to use it, like if they're going to be submitting a grant, you know, can they put in some dollars? Because if they want to implement their tool on ePrognosis, can they, you know, make a dissemination implementation argument for a few $1,000s? You know, we're a bunch of researchers who have discretionary funds. It only is about $500 to sustain a website, you know, depending on which academic institution you're at. So that's not that much money, especially divided into people. And so there's creative ways. I mean, we have been approached for advertising and that kind of thing, but we're all, you know, NIH-funded researchers and didn't think that would be in our advantage because then we'd be more conflicted. So it does take some creativity, but we do everything very low cost.
Okay, why don't we ask her? Go ahead.
So Mike Berry from Boston, just great work all around. And maybe that's a nice segue into just the broader implementation challenge and sustainability. So for Mara, and seeing this through the lens of the U.S. Preventive Services Task Force, the vision would be someone coming in to see a clinician, your grandmother, who would then call up the website, answer the 18 questions, and get prognosis. But on the other side, then there's disease risk. What would be her risk of developing breast cancer? How would mammography affect it? How would breast cancer risk-reducing medications modify that risk over time? And it sounds like a better world, but the implementation challenge is if clinicians don't have the time, and there's not much data that they actually use risk calculators or prognosis calculators. The last survey I saw, which was dated, that even with the Framingham model or the pooled cohort equation, most doctors say they know about it, they acknowledge they should use it, most say they don't use it, and given the social desirability bias, that's probably an overestimate. So we got to make it somehow easier to become more quantitative if that's the right direction. I don't know if anyone has any thoughts of that.
Well, we actually have a proposal that got a 5 percentile to try to make something like statin choice is sort of an example of as easy as it comes conversation aid where something could give you a decision output and you put in risk factors and minimal risk factors, but we wrote to, like in our application, to make it very minimal amount of risk factor and, you know, health group, click like their good health, poor health to get the output. And we wrote that medical assistance would help and the family would help and the patient would help and everybody would help. So you know, I don't know which way it's going. I am a primary care doctor. I think it is hard to do these tools, but I know that I and all my colleagues occasionally use risk tools for lots of different things. We probably don't use all the tools in every patient at every visit, but you know, a good number of visits I'm using risk tools depending on the need of that patient.
I would like to respond about the time issue. So when we did the pilot study, we recorded visits, 10 from each arm. So we did a 2x2, you know, fully crossed randomized controlled trial. And what was surprising, and the results, I wish I had tweeted more or made it more known, but the length of the visits in the let's say the open, basically high touch arm were significantly shorter than the usual care. So there is a literature on patient-physician communication. If agenda setting's done well, the visit may not be very long because there's not a lot of wondering, not a lot of, by the way, but you didn't really answer this question. I really still want to know about that, doctor. So we, and even just the poster at the pilot study, we just gave patients a little handout that had those the three questions. That arm was also shorter. So there is an argument for using, these communication sort of facilitation tools and skills that could potentially make the communication more efficient, therefore free up some time. Let's say, you can free up 3 to 5 minutes. That's the difference between the average length of visits, 3 to 5 minutes differences between the intervention arms and the usual care arms. That could be a time to introduce decision tool, choice tools. So we built in the ASCVD risk scores into our modules, both in the app and also in the SP coaching sessions. So I'm waiting to find out if we can move the needle on this, in this study also.
The boss just told me we actually do have a minute or two. Sorry, Erica. Although the clock says 0, we're okay.
Hi, Karen Eden from OHSU. So my question is to Steve, with open notes. So does the patient see everything, or are there kind of 2 repositories of notes?
They can see everything. We spend a little bit of time in the course trying to orient them to teach them how to see everything. So it's not always as straightforward as we'd like, but they can literally download all components of the record. At least that's my understanding. You can't go back before 2013, and it takes about 3 days before information to appear in a form that you can then download after a visit.
Hi, I'm Aisha Langford from New York University, and I came in on the second half, so I'm sorry if I missed this part. But I was curious if you could speak to interoperability and if your tools can be integrated into electronic health records, if that's a thought that you all had kind of in designing these things, and kind of how, if at all, that is possible, just assuming that that could be one potential tool to help with dissemination and implementation.
I will start. So we purposefully try to incorporate our tools into the health information services. So patients answer the pre-visit questionnaire that's sent to them through the patient portal. Their answer will show up in the rooming tab, so the MAs will see. They can click on it, and they can. We train the MAs to help the patient, to encourage them to really speak up. Assure them their doctors actually want to know what's most important to them. And then we built a smart phrase for the physicians to use. So whatever patients put in as answers will go into the progress note. Because in the pilot study, we saw doctors scan the patient's answer into the EHR because we designed a paper tool. So yeah, we wanted to try to incorporate it into the normal workflow.
I'll say that we haven't done anything with that exactly, but one of our physicians, Nancy Pondu, who's on our steering committee and who actually led the young adults with depression module, will regularly include a link to the module on an after visit summary, and is really thinking about how we can sort of encourage that a bit more, so that clinicians are making this available to their patients when they're experiencing something new.
And at ePrognosis, we had a workshop on this topic, and we had programmers, and in some ways, one EMR is one EMR, so you can design it for each EMR. But a colleague, Saley, is doing a study at the VA where they're using the information in the chart to try to estimate prognosis and provide that. I'm doing a study where we did it manually to see if the information does help doctors. I don't have the results yet.
I would just say that there's been some challenges implementing in the VA, but this was designed so that it's right next to that blue button. You should be able to access the course. And if anybody has other health systems, I'm trying to disseminate the course and the content around other health systems. So anybody who's interested, please send me an email.
Excellent. And I should say that one of the reasons why people don't use tools is that there's a fundamental cognitive mismatch between the output of these tools and the way people think. And by people, I mean providers as well as patients. So the tools tend to be verbatim, people tend to be gist, and there's a verbatim gist mismatch. But there are sort of cognitive prosthetics we can use that can improve that communication and styles of thinking. I think that's one of the barriers to the greater adoption of some of these great tools.
I have a question for Karen. With DIPACs, there's so much data that's there. Has anybody kept a list of key gaps or themes that they would like people to address? I just think about kind of an advanced crowdsourcing where, people put out, gee, there's a great paper to be written and an analysis to be written on this topic, and is anybody out there who wants to do it?
I think that that's a great idea and something I've thought about a lot as it goes forward, kind of like when we think we need a systematic review in a certain area, that there could be a call put out for that. And I think there is a lot of data in the UK setting, right? There's 110 modules. We don't have that in the US yet. That's what we're hoping to become. But certainly that's another thing when you were just saying email me. If people have areas where they think that there's a need or a gap, I think we want to hear about that, and we want to partner with others to do this. Like, this isn't just for our group. We just trained 40 new investigators in New Mexico, and we're really looking to work with others to really expand this work.
Well, I want to thank you and thank our speakers for a really, really exciting and interesting view of some very useful tools. I think, the Jeopardy question is going to be, what's the difference between a decision aid and a decision tool? And you'll all be able to answer it, right? So a decision tool is a broader approach that includes decision aids. And I think we've seen an incredible range of remarkably successful tools here. And I want to thank the speakers and again, the organizers again. Thank you very much.